you're seeing a patient 4 or 5 weeks earlier. Now, if you're a stage 4 cancer, 4 or 5 weeks may mean, another metastase or not.
Cancer centers right now are under a lot of pressure: staffing, volume, costs. Which area of that pressure hits the hardest, and where can AI make the biggest difference?
From my perspective, personnel. That's the most expensive part. We need not just Moffitt. We need, as providers, we need to leverage, learn how to implement AI to continue to grow in terms of volumes, because we're going to see more and more patients without having to grow in this same linear path of I need to add personnel each time I grow. I get 100 more patients, I need 10 more people to manage that. So this is a promise of AI from an operational point of view and from a cost point of view.
There's so many health centers right now who are running these pilots, and they're so promising. But something is separating those who go from the pilot stage and never quite make it to scale. What is that?
The trap of pilots. Pilots after pilots, that's a word that I ask my team to not use. I don't want to use pilots. I ask them to use phase 1. Why phase 1? Well, because what you're going to learn from your phase 1 means that you're going to either go to phase 2 or do something else. But if you do a pilot, it feels a little bit like isolated. We're trying it, no strings attached, whether it works or not, and so you have plenty of successful pilots that have never scaled up. Another issue that I do see also in the provider world is maybe the lack of a strategic roadmap to implement AI and digital. And so you do pilots, but you don't necessarily always connect them to this long-term strategic roadmap. And so you don't really know if this is the right time to implement it or not.
Where do successful leaders invest in first?
Great question. And at Moffitt, the path we've taken is to think about it through two main lenses. So we're looking at non-clinical application and clinical application. Sometimes these non-clinical applications have also clinical impact. And so that's our way to embrace AI and digital applications. We're digitizing, for example, our pathology right now. And we're trying to digitize as many line of services as we can. And then from there, you can build AI. So I'll give you a very concrete example. Very difficult to retrieve patient charts from patients who are coming to Moffitt from the community centers. And usually when they come to Moffitt, they are fairly advanced in their disease. So time is of the essence. We had an army of people taking phones, calls in and out, day in, day out, to try to retrieve these charts. It was on average 5 weeks. When you get them, it's on average 300-400 pages, all format. Takes on average an hour and a half for a physician to flip through that before this physician can have a conversation with the patient and understand what the situation is. We implemented an AI platform. We can manage 70% of these patient charts through this platform, and on average, it's 7 to 10 minutes per case. So that's the true, real impact of AI, allowing us to bring these patients to Moffitt way faster and to engage with them in a much more effective way. And so you can imagine this is not just an operational benefit. Now we can schedule patients faster. We don't need an army of people on the phone. We can save physicians' time, which is very important. But it's better preparing the physician so it can have a clinical impact as well. You're seeing a patient 4 or 5 weeks earlier. Now, if you're a stage 4 cancer, 4 or 5 weeks may mean, another metastase or not. You see what I mean? So this is real transformation at scale.
Thank you so much.